Imagine this. Your heart, the steady engine of your life, suddenly begins to misfire. One moment, it's got this calm rhythm. The next, a terrifying, chaotic drumming inside your chest.
Yeah, it's a scary thought.
Or worse, a sudden silent stop. These aren't just abstract fears. They're the potentially life-threatening realities of ventricular tachycardia, or VT.
Erratic electrical activity brewing in the heart's lower chambers. It's like a lightning storm has just erupted inside the heart's complex electrical system.
Exactly. But what if medical science has found a way not just to weather that storm, but to navigate its complexities, pinpoint its very source, and extinguish it with, well, incredible precision?
That's exactly what we're diving into today. We're going deep into the world of catheter ablation, specifically for ventricular tachycardia.
Right. We've been looking through a really comprehensive presentation on this topic, and it really lays out the details.
It does. It's quite detailed, and our mission today is to unpack this complex medical intervention.
Understand why it's used, how it's done with such precision, the outcomes, and how it's evolving to treat these really challenging heart rhythms.
And a key thing we'll keep coming back to is how the approach differs quite dramatically, actually, depending on whether the heart is structurally healthy or if it has underlying disease.
Yeah, that seems critical. And we should mention, this deep dive is supported educationally by the London Heartbeats Z Academy in the UK. They offer a lot of courses, over 150 apparently, and you can check them out on social media, Facebook, Instagram, YouTube, for updates. Definitely worth exploring if this topic interests you.
Absolutely. So shall we start with the basics? What exactly is ventricular tachycardia?
Good idea. Let's make sure we're all on the same page. What are these ventricular arrhythmias?
Okay, so ventricular arrhythmias are basically a group of abnormal heart rhythms that start in the ventricles, the heart's main pumping chambers down below. They range quite a bit in severity and pattern.
Right. Not all the same.
Not at all. At the milder end, relatively speaking, you have premature ventricular complexes, or PVCs.
PVCs. I think a lot of people have felt those.
Probably. They're extra early beats coming from the ventricles that interrupt the normal rhythm. People often describe them as that feeling of a skipped beat or maybe a strong thump in the chest. They can be benign, but if they happen really frequently, they can cause problems.
Okay. So extra beats. What's next up the scale?
Then you have ventricular tachycardia itself. Monomorphic VT means a regular, fast heartbeat that's coming from a single, consistent spot or pathway in the ventricles.
So rapid, but like organized, coming from one place?
Exactly. The ECG pattern looks pretty much the same from beat to beat. Contrast that with polymorphic VT, or ventricular fibrillation, VF.
Those sound more serious.
They are much more dangerous. Polymorphic VT has this changing, irregular pattern on the ECG. Sometimes it looks like it's twisting around the baseline that's torsade de pointe.
Right.
And then ventricular fibrillation, well, that's just completely chaotic, disorganized electrical activity in the ventricles. The heart muscle just sort of quivers instead of pumping blood effectively.
And that's the one, that's cardiac arrest, right? It needs a shock.
Immediately life-threatening, yes. VF needs immediate defibrillation to restore a rhythm. Now, a really crucial point and a major theme for us today is whether these arrhythmias happen in a heart that's structurally normal or one with structural heart disease, SHD.
Okay, and SHD means things like damage from a heart attack, scar tissue, weak muscle.
Exactly. Scar tissue from a prior heart attack, weakened muscle from different kinds of cardiomyopathy, maybe congenital heart defects or conditions like ARVC, problems with the heart's actual structure. This is different from idiopathic VT, where the heart looks normal on standard tests.
And this difference, normal heart versus SHD, changes how you approach treatment.
Fundamentally, yeah. The source material actually calls the evolution of VT catheter ablation a tale of two cities.
A tale of two cities. Why?
Because the strategies, the mapping techniques, even the main goals of the procedure are really quite different depending on whether you're dealing with VT in a structurally diseased heart versus a normal one.
Interesting. Two different electrical landscapes needing different maps. Let's look back a bit. How did we get here? From just noticing VT to being able to pinpoint and zap spots inside a beating heart?
It's been a journey, really built on tech advancements and a deeper understanding of the heart's electricity. The source highlights some key milestones.
Like, when did they first really start mapping these circuits?
Well, the very first electrophysiology study, an EP study for VT, was back in 1972.
72. And an EP study is where they put catheters inside the heart.
Right. Guided catheters into the chambers to record the electrical signals directly. To figure out where the arrhythmia is coming from and how it behaves, that's the diagnostic part.
Okay.
Then a few years later, 1978, we saw the first attempts at catheter ablation using a DC shock, a big jolt of direct current through the catheter.
Wow, DC shock through a catheter. Sounds
A
intense.
bit of a blunt instrument, yeah. High energy, significant risks. Around the same time, 1982, surgical VT ablation came along.
So open heart surgery to cut out the bad spot.
Essentially, yes. Identify the spot with an EP study, then physically cut it out or isolate it. It could work. But you're talking major cardiac surgery with a pretty high mortality risk, the source says between 3 and 14%.
Yeah, that's significant. So what moved us away from those riskier methods?
The big shift for catheter treatment was in 1988, with a widespread adoption of radiofrequency ablation, or RFA.
RFA. That uses heat, right.
Right. Instead of one big DC shock, RFA uses alternating current to gently heat a tiny area of tissue right at the catheter tip. It creates a much more precise, controlled lesion or burn. Safer, more effective for a lot of arrhythmias.
And that's still the main energy source used now.
It is, yeah.
Yeah.
The other huge advance was in actually seeing where you were going inside the heart.
Better navigation.
Exactly. In 1998, non-fluoroscopic navigation systems came in. Electroanatomic mapping, or EAM.
EAM. So less reliance on X-ray.
Right. Before EAM, it was mostly fluoroscopy live X-ray, lots of radiation, and only a 2D picture. EAM systems build a 3D model of the heart chamber using electrical signals and track the catheter within that 3D space. Much more intuitive, much more precise, less X-ray.
So you get a 3D electrical map instead of just a flat X-ray image. That must have been revolutionary.
It really was. And then, to get actual eyes inside the heart, intracardiac echocardiography, or ICE, started being used more routinely around 2003.
ICE. That's ultrasound on a catheter.
Exactly. A tiny ultrasound probe giving you real-time images from within the heart chambers. You can see the anatomy, see how well the catheter tip is touching the tissue, watch for complications like fluid building up. Incredibly useful.
I can imagine seeing what you're doing in real time.
Absolutely. And things got even more sophisticated around 2004 with the integration of MDCT multi-detector CT scans and MRI scans into the EAM system.
So you could take a CT or MRI done before the procedure.
Yeah, showing all the detailed anatomy, especially scar tissue.
And overlay it onto that 3D map you build during the procedure.
Precisely. It gives you this amazing anatomical roadmap, especially vital for planning complex ablations in diseased hearts with scar.
So the history shows this progression. Basic recording, risky shocks, surgery, then precise RFA guided by these incredible 3D electrical maps fused with detailed anatomical imaging and real-time ultrasound. Amazing.
It really highlights how far the field has come. Now, the source material digs into the core question. Why do these VTs actually happen? What are the underlying electrical mechanisms?
Right, because understanding why it's happening must guide how you fix it.
Absolutely. The mechanism dictates the whole mapping and ablation strategy. For monomorphic VT, or PVCs, there are basically three main electrophysiological mechanisms.
Okay, let's start with triggered activity. What does that mean? Sounds like something sets it off.
It does. Trigger activity means abnormal electrical impulses that are, well, triggered or initiated by the preceding normal heartbeat, like an electrical aftershock.
An aftershock. Okay.
There are two main types. Early after depolarizations, EADs, happen before the heart cell has fully recovered electrically from the last beat. And delayed after depolarized DADs happen after the cell is fully recovered, but before the next normal beat is supposed to arrive.
And specific VTs are linked to these EADs and DADs.
Yes. EADs are often involved in arrhythmias that happen when the heart rate is slow or when the electrical recovery phase is abnormally long. Think torsade the points, that twisting polymorphic VT or VTs triggered by slow heart rates, bradycardia-induced VT.
Okay, slow heart rate related. What about DADs?
DADs are more typically linked to situations where there's too much calcium inside the heart cells. A classic example is idiopathic outflow tract VT, that common type in structurally normal hearts.
And how do you sort of provoke these in the lab to study them?
Good question. The source mentions that these triggered activity VTs can often be induced during the EP study, using things that increase heart rate or calcium levels like rapid pacing, program stimulation, or giving medications like isoproterenol. Right. Another example linked to triggered activity is Purkinje system-related polymorphic VT or VF, especially after a heart attack. These can be triggered by focal PVCs coming from surviving Purkinje fibers right near the edge of the scar tissue.
Okay, so triggered activity is like an abnormal echo after a normal beat. What's the second mechanism? Abnormal automaticity.
Abnormal automaticity. This one's conceptually a bit simpler. It's when a group of heart cells outside the heart's normal pacemaker system just spontaneously starts firing off electrical impulses on their own.
Like a rogue pacemaker site deciding to take over?
Pretty much, yeah. The source gives vesicular VT as an example, specifically the type that responds to the drug propranolol. Sometimes you can induce this type with isoproterenol too. It's generally thought to be less common as a cause of sustained clinical VT compared to the next mechanism, but it definitely happens.
Got it. Spontaneous firing. And the third big mechanism is re-entry. This sounds like the loop we mentioned.
It is indeed a loop. Re-entry is the most common mechanism for sustained VT, especially in hearts with structural disease. It happens when an electrical impulse gets trapped in a sort of circular pathway.
How does that happen?
You need a few things.
Okay.
Usually a circuit with two connected pathways that have different electrical properties, different conduction speeds, different recovery times. An impulse travels down one pathway, maybe it's slow, and by the time it reaches the end, the other pathway has recovered and is ready to be activated, allowing the impulse to loop back around and just keep going, re-exciting the circuit over and over.
So the electrical signal is essentially chasing its own tail around this loop.
That's a great way to put it. Examples include the verapamil-sensitive type of vesicular VT, that's a reentrant circuit involving Purkinje fibers, different from the automatic type we mentioned. But the really big one, especially in structural heart disease, is scar-related VT. The scar tissue itself creates areas of electrical block and, crucially, areas of very slow conduction. This forms the perfect setup, the perfect substrate for these reentrant circuits to develop, looping around the scar borders or through channels within the scar.
So the scar itself creates the racetrack for the re-entry.
Exactly. Bundle branch reentrant VT is another type, often seen in conditions like dilated cardiomyopathy. It uses parts of the heart's normal conduction system, but in a disease state, to form the reentrant loop.
And are these reentrant VTs typically provoked differently in the lab than the triggered ones?
Yes. Generally.
Yeah.
They're most often induced using programmed stimulation, delivering those precisely timed extra beats to try and initiate the loop by catching the pathways at just the right point in their recovery cycle.
Fascinating. The underlying electrical reason dictates how the VT behaves and how you try to trigger it. So given these potentially dangerous arrhythmias, what are the main treatment options and where does catheter ablation fit in?
The source lays out four main categories of treatment. First up, antiarrhythmic drugs, or AADs.
The traditional medication route?
Right. Often the first thing tried.
Right.
Conventional approach. But the source is pretty clear about their limitations for VT. It says they are mostly inefficacious at actually preventing VT episodes in many patients.
So they don't work that well for prevention.
Often not reliably, no. And they come with baggage. Potential risks, including, in some cases, actually increasing mortality. Plus, they have multiple toxicities and side effects that patients find difficult.
Not ideal. What about implantable cardioverter defibrillators? ICDs, the devices that shock the heart back to rhythm.
ICDs are hugely important. They provide a significant mortality benefit, especially for patients at high risk of sudden cardiac death from VT or VF. They are life-saving devices, no question.
Aye.
But they aren't a cure. They only act when the arrhythmia happens. They shock the patient out of it, which is life-saving, but they don't stop the VT from happening again in the future.
So it's a safety net, not a prevention strategy.
Exactly. Plus, they're expensive. And getting shocked repeatedly by an ICD is, well, it's physically painful and psychologically really tough for patients.
I can only imagine. Okay, what else? Surgical ablation?
Surgical ablation, which we touched on historically. Open heart surgery to modify the heart tissue. It can offer, theoretically, the most complete removal of the bad tissue. But the big downside is that significant mortality risk from the surgery itself, 3 to 14%. It's usually reserved for very specific cases, maybe if someone's having heart surgery for another reason anyway.
Right, high risk. Which brings us to catheter ablation.
Yes, catheter ablation. Using energy like RFA delivered through catheters. The big advantage here is its potential to be curative, especially for certain VTs in structurally normal hearts. It aims to get rid of the problem at its source.
Eliminate the arrhythmia focus itself.
Right. The challenges are that it can be a technically difficult procedure, and there are issues around accessibility, making sure patients can get to centers with experienced operators who do this regularly.
Okay, so comparing those options. Drugs have limits and side effects. ICDs save lives but don't cure, and shocks are tough. Surgery is high risk. Ablation offers that potential cure, particularly in some types, but it's complex.
That's a good summary.
Let's really dig into the ablation procedure now, how it's done, the outcomes. starting with catheter ablation of VT in structurally normal hearts, the first city in that tale.
Right. And a really key point the source makes right away is that patients with idiopathic VT in a structurally normal heart generally have a low intrinsic risk of sudden cardiac death.
That's important. Why?
Because if the risk of dying suddenly from the arrhythmia is low, the main goal isn't just about having an ICD there to rescue you. The focus shifts towards eliminating the arrhythmia that's causing symptoms, affecting quality of life. So a potentially curative strategy like catheter ablation becomes much more favorable, often the preferred approach.
Makes sense. If it's not likely to kill you, but it's making life miserable, you want to get rid of it.
Precisely. The source doesn't list specific indications right here, but it sets the stage by saying ablation is generally favored for symptomatic or frequent idiopathic VT or PVCs.
Okay, so if ablation is the go-to strategy, how do you even start looking for the source in a heart that otherwise looks healthy?
The first clues often come from the standard 12-lead surface ECG. Before any catheters even go in, the specific shape, the morphology of the VT bead or the PVC on that ECG gives the operator crucial hints.
Hints about where it's coming from.
Exactly. It suggests the likely general area in the ventricle where the arrhythmia originates, maybe the entry and exit points of the electrical wave. The source mentions looking up published ECG criteria for help with this interpretation.
So the ECG is like the first rough map coordinate, but you need much more precision once you're inside, right?
Absolutely. The ECG is just a starting point. If it doesn't clearly point to one area, or if you're dealing with a common type like, say, an LBBB like inferior axis idiopathic VT, the source outlines a stepwise mapping strategy.
Okay, walk us through that typical search pattern.
Well, you usually start by mapping the right ventricular outflow tract, the RVOT,
Why they're first?
because it's just a really, really common site for idiopathic VT and PVCs to originate from. So you check the most likely spot first.
Makes sense. Start with the usual suspect. What if it's not there?
If you map the RVOT and don't find the source, the next common step is often to map inside the distal coronary sinus.
The coronary sinus, that's a vein, isn't it?
It is. It runs along the outside groove between the left atrium and left ventricle. Mapping inside it can give you information about tissue nearby, and sometimes it can reveal an epicardial origin, a source on the outside surface of the heart muscle that happens to be right next to where the coronary sinus runs.
Okay. So check the RVOT, then check near that big vein on the left side. Still no luck.
Then you typically move to the left ventricular outflow tract, the LVOT, and the aortic sinus of Valsalva, those little pouches right above the aortic valve.
And how do you get there?
Usually requires going retrograde through an artery, up the femoral artery in the leg, into the aorta, and then across the aortic valve into the left ventricle and its outflow tract, a different route to access the left side.
Okay, so RVOT, coronary sinus, LVO aortic root, mapping the inside surfaces. What if it's still not found?
If all those endocardial inner surface approaches fail, the source says you should consider epicardial mapping via percutaneous pericardial access.
Epicardial, meaning outside the heart muscle itself.
Exactly. You access the pericardial space, the potential space between the heart muscle and the outer sac, the pericardium, usually with the needle puncture below the sternum. This lets you map the outer surface of the heart because some VTs do originate out there.
Wow, that's a comprehensive search. So once you're in the suspected neighborhood based on the ECG and this stepwise mapping, how do you find the exact millimeter-sized spot to ablate?
That's where activation mapping comes in. The source calls it the method of choice for mapping idiopathic VT and PVCs.
Activation mapping, what's the principle?
The core idea is to find the site of the earliest electrical activation within the heart chamber during the actual VT or PVC event. You use a mapping catheter to record the local electrical signals, and you time them very precisely relative to some reference signal, like the start of the QRS on the surface ECG.
So you're literally listening for the very first electrical spark that kicks off the abnormal beat.
That's exactly it. And for this to work, you absolutely must be able to reliably induce the patient's clinical arrhythmia in the EP lab. If the VT or PVCs aren't happening frequently enough during the procedure, you can't map their activation sequence.
Oh, okay. You need the target to be active. How do operators try to make the arrhythmia show up more often during the procedure?
The source lists several ways. You can use rapid burst pacing, deliver programmed extra stimuli, or infuse medications that tend to provoke these arrhythmias, things like isoproterenol, epinephrine, phenylephrine, aminophylline, even calcium infusion or atropine, anything to get the VT or PVCs firing more consistently for mapping.
Right, stir it up so you can see it. And what specific electrical signal tells you, okay, this is the spot?
You're looking for a very early signal on the bipolar electrogram recorded from the catheter tip. The source says this earliest local activation typically happens 15 to 45 milliseconds before the QRS complex starts on the surface ECG.
15 to 45 milliseconds, that's incredibly early.
It is, and often the unipolar electrogram from that same spot shows a characteristic QS pattern, which is another strong indicator that your catheter is right on top of the focal origin.
Okay, earliest activation plus that QS pattern, that sounds like strong evidence. What about pace mapping? How does that work?
Pace mapping is another fundamental technique. It's often used to confirm what you found with activation mapping, or sometimes it's the primary tool if activation mapping is difficult, maybe because the PVCs are too infrequent.
How do you do pace mapping?
You use the mapping catheter to deliberately pace the heart from various sites. Then, you compare the shape, the morphology, of the QRS complex produced by your pacing on the 12-lead ECG to the morphology of the patient's actual target, PVC or VT beat.
So you're asking, if I make the heartbeat start right here, does it look identical to the problem beat?
Exactly. When you find a pacing site where the pace QRS morphology is identical or almost identical across all 12 ECG leads to the clinical VT-PVC, it strongly suggests your pacing site is very close to where that clinical arrhythmia is actually starting.
When would you rely more on pace mapping?
It's particularly useful when the clinical VT is hard to induce reliably or if the PVCs are just too infrequent during the procedure to get good activation data. You could do pace mapping while the heart is in its normal sinus rhythm.
Is it as precise as activation mapping?
Generally, no. The source notes pace mapping usually has lower specificity. It might give you a slightly broader area. Activation mapping, finding that earliest electrical signal, tends to give better spatial resolution, pinpointing the origin more precisely. Ideally, operators try to use both activation mapping and pace mapping to cross-reference and confirm the target site.
Got it. Activation mapping finds the when, pace mapping finds the where it looks like, and using both gives you more confidence.
Well put.
The source then gets into ablation for specific types of idiopathic VT, starting with fascicular VT.
Right. Fascicular VT arises from the Purkinje system,
Yeah.
usually in the left ventricle. It's often called verapamil-sensitive VT, or Bell-Hassan tachycardia. For the type that's reentrant and can be induced in the lab,
Yes.
you can use entrainment mapping. That's a technique we'll talk more about with structural heart disease. But basically, you pace during the VT to prove you're in the circuit and find critical spots, often targeting specific Purkinje potentials or diastolic potentials within that circuit.
Okay. But what if you can't induce that fascicular VT during the procedure?
That's a challenge. In that situation, you might have to resort to substrate ablation. For non-inducible reentrant fascicular VT, the strategy described is to create a linear lesion, a line of ablation, in a specific anatomical area, usually the mid to mid-inferior septum, running perpendicular to the long axis of the ventricle.
So you ablate the likely pathway area even if you can't see the VT running through it at that moment.
Exactly. You're trying to empirically interrupt the presumed circuit based on its known anatomy. There's also a focal type of Purkinje VT, which is thought to be due to abnormal automaticity or triggered activity. For that, you'd use activation mapping, looking for the earliest presystolic Purkinje potential during the VT.
And finding the specific type matters.
Critically, the source stresses how important it is to distinguish fascicular VT from interfascicular VT and bundle branch reentrant VT, because the mapping and ablation approaches are quite different for each.
Makes sense. Different circuits need different strategies. The source also mentions PVC-triggered polymorphic VT and VF in this section, even though we often think of those with heart disease.
Right. Sometimes, even in structurally normal hearts or those with underlying channelopathies, genetic electrical issues, dangerous arrhythmias like polymorphic VT or VF can be triggered by what seem like isolated PVCs.
So a single PVC type can set off VF.
It can. The source notes that in one series, these triggering PVCs came from the Purkinje system in 83% of cases, or from the ventricular muscle itself, like the RVOT, in 17%.
And ablating just that triggering PVC could prevent the polymorphic VT or VF.
That's the idea. Find the consistent PVC morphology that initiates the dangerous rhythm, map its origin using activation and pace mapping, and ablate it. The source links this phenomenon not only to structurally normal hearts or channelopathies like long QT or Brugada, but also mentions it can happen post-heart attack, where PVCs from surviving Purkinje fibers near the scar can trigger VF.
That leads nicely into Brugada syndrome, which gets special mention.
Yes, Brugada is a genetic condition associated with a high risk of sudden death, usually from polymorphic VTTF. The source says the triggering PVCs in Brugada often originate from the RVOT. But the really fascinating part here is relatively recent research.
What's that?
It shows that in Brugada, you can actually map and ablate the underlying substrate itself, the abnormal tissue that makes the heart vulnerable to VF in the first place.
Not just the trigger, but the underlying electrical problem. Where is this substrate?
It's typically found on the epicardium, the outer surface of the RVOT. It's characterized electrically by abnormal, low-voltage, fractionated signals. And what's remarkable is that ablating this epicardial substrate has been shown not only to prevent future VF episodes, but also to normalize the patient's characteristic type 1 Brugada pattern on their ECG.
Wow, ablation can actually normalize the Brugada ECG. That's incredible. That's addressing the root electrical vulnerability.
It's a very powerful application, yes. Really changes the game for managing some Brugada patients.
So looking at the big picture for structurally normal hearts, it sounds like ablation is generally quite successful and safe. What do the outcomes and safety data show?
The source presents outcomes referencing a 2016 European Heart Journal article. For instance, in PVC-induced cardiomyopathy, where very frequent PVCs actually weaken the heart muscle over time.
Right, the PVCs themselves cause the heart failure.
Exactly. Successful ablation, defined as getting rid of more than 80% of the PVCs, led to significant improvement in heart function, the LVEF. 67% of patients had their LVEF improved by more than 10%, and another 18% saw smaller improvements. It shows that this type of cardiomyopathy is often reversible if you ablate the PVCs.
That's a great outcome. Fixing the rhythm fixes the heart muscle function. What about for those PVC-triggered polymorphic VTVF cases?
High success rates reported there, too. Around 82% freedom from recurrent VF over a median follow-up of 5 years. And even if it comes back, successful repeat ablation is often possible. Good to know. And what about the risks, the complications in these structurally normal heart cases? The source said rare.
Generally rare, yes. Reported rate around 3–5%. The most common issues are related to the vascular access site where the catheters go in the leg or neck. Things like bruising, hematomas, pseudoaneurysms, occurring in about 2%.
Okay, access site issues. What about more serious things?
Less common, but possible. Cardiac tamponade fluid building up around the heart, needing drainage happens in about 0.8%. Thromboembolic events like a stroke are very rare. Damage to the heart's normal conduction system requiring a pacemaker, AV block, is also rare, about 0.1%. An injury to a coronary artery is another rare possibility. And does the location matter for risk?
Interestingly, yes. The source notes that major complication rates tend to be lowest for ablations done in the RVOT, which is the most common site for idiopathic VT anyway.
So overall, low risk, especially compared to the potential danger of the arrhythmia itself, but not zero risk. What happens when ablation fails in these cases? Why might it not work?
The source lists several common reasons for failed ablation. One is simply imprecise mapping, maybe not finding the absolute exact spot, or the map wasn't quite accurate enough.
Didn't hit the bullseye.
Right. Another is inability to actually reach the site. The origin might be too deep inside the muscle wall intramural or on the epicardial surface, and maybe epicardial access wasn't done or wasn't successful.
If you can't get the catheter tip there.
You can't ablate it. Other factors include limited power delivery, maybe not enough energy gets to the tissue, or inadequate catheter stability, where the catheter tip moves around too much with heartbeats or breathing to create an effective lesion.
Right. Need good contact and stability.
But perhaps the most common and frustrating reason, especially given the reliance on activation mapping, is a paucity of the arrhythmia during the procedure. If the PVCs or VT just aren't happening very often while the operator is trying to map.
You can't map what's not there.
Exactly. You can't find the earliest activation if there's no activation to find.
That makes complete sense. How do operators try to get around these challenges?
They have several tools and tricks. To improve mapping, especially with infrequent beats, they might use multi-electrode array catheters that can listen at many spots simultaneously. Intracardiac echo, ICE, is huge for visualizing tricky anatomy like papillary muscles and ensuring good catheter contact.
Using that internal ultrasound view.
Yes. To get more PVCs, they might adjust sedation levels or use those provoking medications we mentioned, like isoproterenol or calcium. If the source is suspected epicardially, they'll go for epicardial ablation. And newer catheters with contact force sensing give real-time feedback on how hard the tip is pressing, which helps optimize energy delivery and stability.
Lots of tech trying to overcome the hurdles. Is there one standout reason for most failures?
The source identifies the inability to reliably induce the PVCs or VT during the procedure as the single most common cause of unsuccessful ablation in this setting. If you can't provoke it, you often can't map it accurately enough to ablate it effectively.
Got it. The target needs to show itself. Okay, so summing up, idiopathic VT ablation. It's mature, often curative, relatively safe, but success really hinges on precisely finding and hitting that electrical spot, which requires the arrhythmia to cooperate during the procedure.
That's a fair summary.
Now, let's make that big shift. Let's talk about catheter ablation of VT in structural heart diseases, SHD, the other city.
Right, and this is a completely different ballgame. Patients with structural heart disease and VT are at a significantly higher risk for sudden cardiac death.
Much higher risk than the idiopathic group.
Much higher. Because of this, implantable cardioverter defibrillators, ICDs, are the absolute cornerstone, the mainstay of therapy for these patients. They need that device ready to deliver a life-saving shock.
Okay, so the ICD is primary. What's the role of ablation then? It's not usually curative here, is it?
Generally not curative in the same way as idiopathic VT, no. Here, ablation serves primarily as adjunctive therapy. Its main role is to treat or prevent frequent symptomatic VT episodes, and very importantly, to reduce the frequency of those ICD therapies, the shocks.
So it's about reducing the burden of VT and shocks, making life better for the patient living with the ICD.
Exactly. It's used when antiarrhythmic drugs haven't worked well enough, or the patient can't tolerate them, or they simply prefer to avoid long-term drug therapy if possible. The goal is often not to eliminate every single possible VT circuit, but to get rid of the ones that are causing symptoms or triggering the ICD frequently.
Makes sense. Reduce the electrical storminess. So the indication is mainly symptom and shock reduction. How does the approach differ, given that the mechanism is usually re-entry around scar?
Because it's typically scar-based reentry, the mapping strategy is fundamentally different. You're not just looking for a single earliest point of activation. You're trying to find and characterize the myocardial scar tissue itself, and specifically identify the critical isthmus.
The isthmus, that narrow channel within the scar the circuit has to go through.
Precisely. The bottleneck of the reentrant circuit. Ablating that isthmus is often the key to stopping that specific VT. The source outlines the approach in SHD in a stepwise manner. Step 1 is characterization of target VTs.
Okay, what does that involve? Characterizing the VTs?
It means trying to understand all the different VTs the patient might have. This includes VTs that have been documented clinically, like on a Holter monitor or when their ICD went off, and also any VTs that can be induced with program stimulation during the EP study.
And how is that program stimulation done in SHD, similar to idiopathic?
Similar principle, but often more aggressive because you're dealing with scar. Typically performed using maybe 2 different baseline pacing rates, and then delivering up to 3, sometimes even 4, extra stimuli at progressively shorter intervals. And usually done from at least 2 different locations in the ventricle, like the apex and the outflow tract.
Why go through all that effort to induce VTs?
It's crucial for several reasons. It helps confirm the diagnosis and understand the characteristics of the VTs the patient is prone to. It helps rule out things like bundle branch reentrant VT, which needs a totally different approach.
Yeah.
When you do induce a VT, capturing its 12-lead ECG morphology is vital for later pace mapping to find the exit site.
Right, get a fingerprint of each VT.
Exactly. And program stimulation also serves as an endpoint. If you ablate and then you can't reinduce any VT using the same aggressive stimulation protocol, that suggests you've successfully modified the substrate.
Okay, so you provoke them to study them, and then try to provoke them again afterwards to see if you fixed it. What happens when a VT is induced in a patient with SHD during the study? They might not tolerate it well, right?
Often they don't. Many VTs in SHD are very fast and cause the patient's blood pressure to plummet. They become hemodynamically unstable. If the VT is stable enough, the operator might try to terminate it pace slightly faster to break the circuit. But frequently it requires an immediate electrical cardioversion, a shock, to restore normal rhythm.
Okay.
After stopping the VT, they often repeat the stimulation protocol to see if the same VT, or maybe different ones, can be induced. And for every distinct VT morphology that comes up, the team meticulously records its characteristics.
What kind of characteristics?
The full 12-lead ECG pattern, the rate or cycle length, the shape, like bundle branch block pattern. The electrical axis where the pattern shifts across the chest leads precordial transition. And critically, its hemodynamic effect was it stable or unstable.
That's a lot of data for each VT.
It is, but it's all valuable information that helps the operator localize the likely exit site of that VT from the scar and plan the overall ablation strategy.
Got it. Step 1. Understand all the VTs. Then step 2 is delineation of the arrhythmic substrate. This sounds like mapping the scar itself.
Exactly. In SHD, since reentry around scar is king, the main focus shifts to meticulously identifying and characterizing that scar tissue. This is where those 3D electroanatomic mapping systems, EAM, are absolutely essential.
How do they map scar specifically? Using voltage.
Primarily, yes. The EAM system builds that 3D model of the ventricle. Then as the mapping catheter is moved around inside, it records the voltage of the local electrical signals. The system creates a color-coded map based on these voltage amplitudes.
High voltage means healthy tissue.
Right. High voltage signifies healthy, normal heart muscle. Very low voltage indicates dense scar tissue, which is electrically inert or nearly inert. And the areas in between, with intermediate voltage readings, represent the border zone.
The border zone, that's the dangerous area.
Often the most critical area, yes. It's a mix of scar and surviving muscle fibers. Conduction through this border zone is often very slow and fragmented, which is perfect for setting up those reentrant circuits. The EAM systems also help identify potential channels or isthmuses within the scar based on voltage and the characteristics of the electrical signals recorded there.
So the colors on the map show healthy, dense scar and that crucial border zone. Are there specific voltage numbers used?
There are standard cutoffs, yes. For endocardial bipolar voltage mapping, typically, greater than 1.5 millivolts MV is considered normal. Between 0.5 millivolts and 1.5 milliV is the border zone. And less than 0.5 milliV is dense scar. Unipolar voltages, which look at a larger tissue area, also have criteria like the 8.27 milliV in the LV and EO 5.5 milliV in the RV, typically being normal.
Okay. And you mentioned identifying abnormal electrical signals within these scar and border zones.
Yes, besides just low voltage, the quality of the electrogram is key. You look for fractionated electrogram signals that are prolonged, messy, with multiple components indicating very slow, disorganized conduction.
Right.
And perhaps even more importantly, you look for local abnormal ventricular activity, or LVA. These are also sometimes called late potentials or isolated potentials.
LAVA. What are those exactly?
They are distinct, sharp electrical signals that occur late in the cardiac cycle, well after the main QRS complex is over, usually separated from it by an isoelectric baseline, a flat line, of 20 milliseconds or more.
So little electrical blips happening way after the main beat within the scar. What do they represent?
They're thought to represent very delayed activation of small bundles of surviving muscle fibers within the scar, often indicating pathways involved in slow conduction zones or the critical isthmus of a reentrant VT circuit. They're like electrical footprints of the arrhythmia circuit hiding in the scar.
Finding those LVA signals sounds really important then.
Hugely important. The source emphasizes that eliminating these LADA potentials during ablation is increasingly recognized as a critical procedural endpoint, maybe even more important than just rendering the original VT non-inducible.
Yeah.
Getting rid of LAV is associated with better long-term freedom from recurrent VT and death, and it's seen as a marker of successful substrate modification.
Wow. So targeting those specific late signals within the scar seems key to durable success in SHD ablation.
It appears so, yes.
Do these scar patterns and LAVA locations tend to occur in predictable places depending on the type of heart disease?
Yes, there are typical locations, and knowing this helps guide the mapping strategy. For scar after a heart attack, post-MI, it's usually subendocardial inner layer in the area supplied by the blocked artery. In dilated cardiomyopathy, DCMP, the scar is often different, maybe mid-myocardial, middle of the wall, or epicardial outer surface, frequently in the basal regions like anteroseptal or infraoral LV.
Different diseases, different scar locations.
Exactly. In ARVCD, arrhythmogenic right ventricular cardiomyopathy dysplasia, it classically starts on the epicardial surface of the RV and progresses inwards. HOCM, hypertrophic obstructive cardiomyopathy, can have patchy scar. Sarcoidosis often involves the basal septum, frequently epicardial or transmural through the whole wall. Chagas disease typically affects the inferolateral and apical LV, often both endo and epicardially. Knowing these patterns helps the operator anticipate where to look.
That anatomical knowledge must be crucial. The source also mentioned using imaging to help map the substrate. Image-guided substrate mapping.
Yes. This is becoming increasingly standard, especially for complex cases. Voltage mapping alone can sometimes struggle to fully define scar that's deep in the wall, like mid-myocardial or septal scar.
So imaging helps see those hidden areas. How?
Cardiac MRI with late gadolinium enhancement, or LGE MRI, is particularly powerful. Gadolinium contrast agent washes out of healthy muscle quickly but gets trapped in scar tissue, making the scars show up as bright white areas on the MRI scan.
LGE shows the scar.
Right. And you can take this detailed LGE MRI map of the scar, showing its precise location, whether it's endocardial, epicardial, mid-myocardial, transmural, and integrate it, fuse it with the 3D electroanatomic voltage map created during the procedure.
So you overlay the anatomical scar picture onto the electrical map.
Exactly. It provides an incredibly valuable anatomical roadmap guiding the catheter to the areas of interest, especially helpful for finding those tricky septal or mid-wall substrates common in non-ischemic cardiomyopathy, but also useful in ischemic cases.
That sounds like a game changer for planning. What about patients with ICDs? Can they get MRIs?
That used to be a major limitation, yeah. Concerns about device safety and image artifacts obscuring the heart. But the source notes that techniques and protocols have been developed for safe MRI scanning in many patients with ICDs now, and special wideband LGE sequences can significantly reduce the artifacts caused by the device generator.
Good to know they're finding ways around that. Any other imaging mentioned?
The source briefly mentions CT scans also being explored to define VT substrate and non-invasive mapping approaches that combine body surface ECG mapping, using vests with hundreds of electrodes, with CT or MRI imaging to try and localize VT origins before the invasive procedure. It highlights this trend towards integrating multiple imaging modalities.
Okay, so we've done step 1, characterize the VTs. Step 2, meticulously map the scar substrate, ideally using voltage mapping combined with integrated imaging like LGE MRI, looking for low voltage, fractionated signals, and especially LAV. Now, step 3. Ablation strategies of the arrhythmic tissue. How do you actually target the ablation?
Once you have the map and understand the VTs, the source lists the primary ablation techniques used in SHD: entrainment mapping, activation mapping, pace mapping, and substrate modification ablation.
Let's start with entrainment mapping. We touched on it for fascicular VT. How is it used to confirm reentrant circuits in SHD?
In SHD, entrainment mapping is considered the gold standard, the most reliable method, for proving that a specific site you're mapping is actually part of the critical reentrant circuit causing a particular VT.
How does it prove that?
Entrainment is defined as continuously resetting the timing of the reentry circuit by pacing from your catheter tip at a rate slightly faster than the VT itself. If you can consistently reset the VT without changing its morphology, shape on the ECG, it strongly suggests your pacing site is electrically connected to and participating in the circuit.
Pacing captures and resets the loop?
Exactly. There are specific criteria you look for during pacing, like the post-pacing interval, PPI, compared to the tachycardia cycle length, TCL, the stimulus to QRS interval, and whether the fusion is concealed, meaning the paced beat looks identical to the VT beat, suggesting pacing from within the protected isthmus. The source references diagrams illustrating all these complex concepts. Demonstrating entrainment with specific characteristics provides strong evidence that the site is critical.
Sounds like a very powerful technique for confirming you're in the right spot for a specific VT. What's the upside?
The big pro is its high predictive value for stable, sustained VT. If you find a site that meets strict entrainment criteria, like PPI TCL, 30 meters concealed fusion, ablating that site has a very high probability, reportedly near a 100% positive predictive value, of terminating that specific VT.
That's incredibly useful if you can do it. But you mentioned earlier, many SHD VTs aren't stable enough.
And that's the major downside, the huge limitation. The source points out that something like 80% of VTs induced in SHD patients are either non-sustained, they stop on their own quickly, or they cause hemodynamic collapse, making detailed entrainment mapping impossible.
So the gold standard technique often can't be used because the target VT won't cooperate or the patient can't tolerate it.
Precisely, which is why the source concludes that, in practice, pace mapping and substrate mapping strategies are the actual mainstay for VT ablation in the majority of SHD patients. You can do those techniques even if the VT isn't inducible or stable.
Okay, so entrainment is great when feasible, but often isn't. What about activation mapping in SHD? How does it differ from its use in idiopathic VT?
In SHD, for reentrant VT, you're generally not looking for a single absolute earliest point, like in focal idiopathic VT, because it's a circuit. Instead, activation mapping focuses on identifying areas within the scar that show continuous diastolic electrical activity signals happening all the way through the period between the main heartbeats.
Suggesting ongoing slow conduction within the scar loop.
Exactly. Or finding those discrete isolated diastolic potentials, like the LAVA signals we discussed. These indicate late activation within the scar. It helps identify regions of interest, areas of slow conduction. However, finding the exact critical isthmus just based on activation timing alone is less reliable for reentrant VT compared to focal VT. Some diastolic signals might just be innocent bystanders, slow conduction not essential to the main circuit.
So useful for finding abnormal areas, but maybe not pinpointing the critical path alone for reentry. Could it be useful for triggered activity in SHD?
Yes, the source notes it's a useful adjunct and potentially more reliable if the VT in an SHD patient is actually due to triggered activity or abnormal automaticity originating from a focal spot within or near the scar rather than reentry.
Okay. What about pace mapping in SHD? Still comparing paced beats to the clinical VT.
Yes, pace mapping remains very useful in SHD, especially when entrainment isn't possible. You use it to identify the arrhythmia source if it's focal, or much more commonly in SHD, to identify the exit site of a reentrant VT.
The spot where the wave leaves the scar to activate the rest of the ventricle.
Right, you pace from various sites in and around the scar border zone, looking for the spot where the paced 12-lead ECG morphology best matches the morphology of the clinical VT you're targeting. A good match suggests you're near the exit, which is often close to or part of the critical isthmus.
So find the spot that mimics the clinical VT. Does pace mapping give other clues in SHD?
Yes, a really important one is the stimulus to QRS, SQRS interval during pacing. That's the time delay between your pacing stimulus and the start of the resulting QRS complex. A long SQRS interval, say 80 milliseconds or more, indicates significant conduction delay between your pacing site and where the impulse finally exits the scar. These long SQRS sites are highly suspicious for being located within or very near the slow-conducting critical isthmus of the VT circuit.
That long delay is a big red flag for the slow zone.
It is. Pace mapping can also help define the extent of dense, unexcitable scar if you need a very high output, like 10 milliamps, to capture the tissue.
Got it. Pace mapping helps find the exit and potential slow zones. Now let's talk more about substrate ablation or substrate modification. This seems like a major strategy when you can't map specific VTs.
It is. Substrate ablation is a cornerstone approach in SHD, especially for patients with unmappable VTs, non-inducible or unstable, or multiple different VT morphologies suggesting a complex substrate. The concept comes from the older surgical idea of just removing or modifying the arrhythmogenic scar tissue itself.
So instead of chasing a specific active VT circuit, you proactively treat the abnormal scar tissue identified on the voltage and imaging maps.
Exactly. You target areas based on the substrate map, low voltage areas, border zones, regions with fractionated signals, or LAVA potentials. The goal is to electrically homogenize or isolate these areas, making them less capable of sustaining reentrant circuits. Common strategies involve creating lines of ablation lesions to transect potential channels or isthmuses within the scar, or ablating all identified LAVA potentials, or extensively ablating the entire border zone.
Does targeting the substrate like this work better than just going after the specific VTs you can induce?
Evidence suggests it does lead to better long-term outcomes. The source highlights the VISTA trial, which compared ablating only the inducible clinical VT versus doing that, plus additional substrate ablation in patients with ischemic cardiomyopathy and stable VT. The group that got the extra substrate ablation had significantly higher freedom from recurrent VT at 1 year, about 85% versus 52%, with no difference in safety.
That's a striking difference. Suggests being more comprehensive and treating the star substrate pays off.
It really does seem to improve the durability of the procedure in SHD.
Okay, during these often long and complex SHD ablations, especially if inducing VT makes the patient unstable, the source mentions using external hemodynamic support devices. Tell us about those.
Right, VT ablation in SHD patients, particularly those with very weak hearts, low LVEF, can be risky because inducing VT for mapping, or even the ablation itself, can cause profound hemodynamic instability, a dangerous drop in blood pressure. Hemodynamic support devices are used to maintain adequate blood flow and organ perfusion during these high-risk procedures.
What kind of devices are we talking about?
Things like an intra-aortic balloon pump, IABP, which helps support pressure, More powerful are percutaneous left ventricular assist devices, like the Impella device, which is a small pump inserted via catheter into the LV to actively pump blood into the aorta. And for maximal support, there's extracorporeal membrane oxygenation, ECMO, which basically takes over heart and lung function externally.
ECMO is serious support. Who gets these devices during ablation?
Their use is generally reserved for the highest risk patients. People who've maybe failed previous ablation attempts, have recurrent episodes of very fast, unstable VT, or have severely impaired LV function to begin with, making them very likely to decompensate during the procedure.
So, primarily for safety and stability in very sick patients, does using support actually help map the VT better by making it more stable?
That's an interesting point the source makes. While you might think stabilizing the patient would allow for better mapping of unstable VTs, studies haven't shown that using support just for that purpose actually improves short-term ablation success or long-term freedom from VT. Their main benefit seems to be getting these very high-risk patients safely through the procedure itself.
Okay, so support is for safety, not necessarily a mapping aid per se. After you've done the ablation in SHD, targeting isthmuses or substrate, how do you know if you were successful? What's the end point of the procedure?
That's actually a somewhat debated topic, and the best endpoint isn't perfectly defined. However, the source indicates that the current understanding, based on several studies, is that achieving complete VT non-inducibility after the ablation is associated with the best long-term outcomes.
Non-inducibility meaning you try to provoke VT again with aggressive stimulation and you can't get any VT to start.
Exactly. Complete non-inducibility of any VT using the same protocol that induced VT before the ablation.
And achieving that endpoint correlates with, what, fewer future VTs?
Yes, and importantly, it's also been linked to reduced all-cause mortality in patients with non-ischemic cardiomyopathy and longer survival with lower recurrence of VT or VF in patients with post-infarction VT.
That's significant. Making the heart electrically stable enough to resist provocation seems to translate to better overall survival.
It appears so. Therefore, the source concludes that aiming for non-inducibility of any VT is a reasonable procedural endpoint in SHD ablation.
There's a catch, right? You mentioned earlier it's often hard to test for this immediately after.
Yes, that's the practical limitation. Many of these SHD patients are quite fragile immediately post-ablation, perhaps still recovering from anesthesia or the procedure itself, and performing aggressive program stimulation right then might be considered too risky due to potential hemodynamic instability. So, while non-inducibility is the goal, confirming it acutely isn't always feasible.
Okay, understandable. The source also brings up the timing early vs deferred VT ablation. Is it better to ablate sooner rather than later in SHD?
There's growing evidence suggesting yes. Early ablation, defined maybe as within 30 days of the first documented VT episode, seems to be associated with a lower rate of VT recurrence down the line, compared to waiting longer to perform the ablation.
So intervening early might nip it in the bud more effectively.
Possibly. The source also discusses the advantages of preventative catheter ablation. May be done around the time of ICD implantation, or relatively early in the course, even before frequent shocks occur. Doing it preventively or early appears to significantly reduce the number of subsequent ICD shocks the patient receives, reduces the chance of electrical storm, and might even contribute to an improved overall prognosis.
And is doing it early riskier?
Importantly, the source notes that performing ablation earlier doesn't seem to be associated with significantly increased procedural complications or mortality compared to doing it later. So the trend seems to be towards considering ablation earlier in the disease course for SHD patients with VT rather than waiting until they're having very frequent shocks.
That makes a lot of sense. Address the substrate before it causes repeated major problems. Let's revisit the overall outcomes and safety profile specifically for ablation in SHD. What are the complication rates like?
As expected, they are higher than in the structurally normal heart group. The source quotes an overall complication rate of around 8%.
And what are the most common serious issues?
Similar types of complications as in idiopathic ablation, but occurring more frequently. Access site vascular problems are still common. Cardiac tamponade and thromboembolic events, like stroke, are the next most frequent major complications.
What about the patient's outcome long term, like mortality?
This reflects the underlying severity of their heart disease. The source states overall long-term mortality for SHD patients undergoing VT ablation ranges widely, from 4% up to 22%. A key risk factor during the procedure itself is OBA, acute hemodynamic decompensation, that sudden drop in blood pressure occurring in about 11% of cases and associated with significantly increased mortality. This highlights the need for careful patient selection and potentially hemodynamic support.
Are there factors that predict who is more likely to have complications?
Yes, the source lists independent predictors. Older age, having kidney problems, renal insufficiency, having a very low ejection fraction, poor heart pump function, and importantly, operator and center experience.
Experience really matters for these complex cases.
Absolutely. It underscores that these procedures should ideally be done in high-volume centers with experienced teams. Now, a crucial point about mortality impact.
Yeah.
While ablation significantly reduces VT recurrence, the source states it hasn't been shown to significantly impact overall mortality when the patient already has an ICD. The ICD is still providing that ultimate protection against sudden death.
So ablation doesn't necessarily make them live longer if they have an ICD, but it improves quality of life by reducing shocks.
Primarily, yes. However, there's a nuance. Achieving freedom from VT recurrence for at least a year after ablation is associated with improved transplant-free survival, regardless of how bad their heart failure was initially. So controlling the VT seems to help their overall heart health trajectory, even with the ICD backup.
That's an important distinction. Reducing the arrhythmia burden helps the heart long term. Is there a risk of the ablation itself worsening heart failure?
It's a theoretical concern, creating scar tissue in an already damaged heart. But the source suggests this is less likely to be a major issue when performed by experienced operators using careful techniques.
Okay. Let's briefly touch on failed ablation and SHG again. Are the reasons the same as in normal hearts?
Many are the same.
Yeah.
Imprecise mapping, inability to reach deep intramural or epicardial sites, limited power delivery or catheter stability, lack of inducible VT. But a challenge more specific to SHD is the proximity of the target scar tissue to vital structures,
Like what?
like the His bundle, part of the normal conduction system, major coronary arteries, or the phrenic nerve controlling the diaphragm. The critical VT isthmus might be located right next to one of these, making it unsafe to deliver ablation energy there without causing serious collateral damage.
So you might identify the spot, but be unable to safely ablate it.
Exactly. That's a major challenge. Ways to overcome failure include trying epicardial ablation if the source is suspected externally, using those ancillary techniques we'll discuss, or in very refractory cases, considering surgical or hybrid ablation. And again, the source reminds us that assessing acute success by checking for non-inducibility isn't always possible due to instability.
Right. Let's focus on epicardial ablation for a moment. We know it accesses the outside of the heart. When is it particularly indicated in SHD?
It's crucial when the VT substrate is located on or near the epicardial surface. This is suspected after a failed endocardial ablation, or based on the type of heart disease, like DCM, ARVC, Chagas, sarcoidosis, where epicardial involvement is common, or if the LGE MRI clearly shows epicardial scar, or even if the 12-lead ECG morphology of the VT strongly suggests an epicardial exit site.
So multiple reasons might point towards needing that outside approach, and access is usually via that subxiphoid needle puncture.
Usually percutaneously via a subxiphoid approach, yes, although sometimes a small surgical incision is used. It allows access to the pericardial space to map and ablate the heart's outer surface.
A key tool for otherwise unreachable targets. Now, you mentioned advanced technology and ancillary techniques beyond standard RFA. What's being developed or used for these tough cases?
There's a lot of ongoing research to find ways to create more effective, deeper lesions, especially for those intramural or thick epicardial substrates that standard RFA might not penetrate sufficiently. The source lists several ancillary techniques.
Give us some examples.
Okay, there's transcoronary ethanol ablation. You find a small cardiac vein running over the target tissue and inject ethanol alcohol into it, which chemically ablates the tissue supplied by that vein.
Alcohol ablation via a vein. Interesting.
Yeah. Then there's bipolar RF ablation, where energy is delivered between the catheter tip and maybe another catheter or a large surface patch, which can sometimes create deeper lesions than standard unipolar RFA, tip to grounding patch. Irrigated needle ablation uses a catheter with a deployable needle tip that can inject RF energy deeper into the muscle.
A needle delivering RF deeper inside the wall.
Right. And then there's stereotactic radioablation. This is completely non-invasive. It uses highly focused beams of radiation delivered from outside the body, like in cancer treatment, to target VT substrates identified on imaging. It's still experimental, but being explored for patients with very refractory VT who have run out of other options.
Radiation therapy for VT. That's really pushing the envelope. Any others?
Autonomic modulation is another approach targeting nerves that influence heart rhythm stability, like cardiac sympathetic denervation, usually surgical. High-frequency focused ultrasound is being explored. And electroporation, or pulsed field ablation, is a newer energy source that uses very short, high-voltage electrical pulses to selectively damage heart muscle cells while potentially sparing adjacent structures like nerves or blood vessels. It's generating a lot of excitement.
Electroporation sounds like a different way to target the tissue. Lots of innovation happening. To help clinicians navigate all this, the source refers to key guidelines and consensus statements.
Yes, these professional society documents are vital for summarizing the evidence and providing guidance. The source highlights the 2017 AAEC-CHRS guideline for management of ventricular arrhythmias.
What does that guideline say about ablation in structurally normal hearts?
It gives strong recommendations, class I meaning beneficial, should be performed, for catheter ablation in patients with symptomatic VAs from common sites like the outflow tracts or papillary muscles or specific types like vesicular VT, Bell-Hassan tachycardia. If the arrhythmia is bothersome and hasn't responded to meds, or the patient can't tolerate meds, or they simply prefer ablation up front, the evidence level is mostly BNR, non-randomized studies.
So, for common symptomatic idiopathic VTs, ablation is a primary, strongly recommended option.
Yes. Similarly, for recurrent idiopathic polymorphic VTVF, triggered by consistent PVCs, ablating the trigger gets a Class I recommendation. For PVC-induced cardiomyopathy, ablation is Class I if symptoms or declining LV function are thought due to frequent PVCs, Fiji 15% burden, and meds haven't worked or aren't desired.
And for Brugada syndrome.
Also, Class I recommendation for ablation in patients who have recurrent VT storm or aborted sudden death despite having an ICD, or if they're ineligible for or decline an ICD. This supports that epicardial substrate ablation strategy.
Strong guideline backing across the board for idiopathic VTs. What about the 2017 guidelines approach to recurrent VA in patients with SHD, ischemic or non-ischemic?
It provides an algorithm. For polymorphic VTVF and SHD, first look for reversible causes, drugs, ischemia, electrolytes. Amiodarone is Class I. Catheter ablation is Class I if you can identify consistent PVC triggers. Autonomic modulation is Class I, may be considered.
Okay, and for the more common sustained monomorphic VT and SHD?
If ischemia is present, revascularization is Class I. For ongoing VT, antiarrhythmics like amiodarone or sotalol are Class I. Catheter ablation is also Class I, typically as an adjunct to the ICD for recurrent VT. Ablation can be considered first line over drugs in some cases, Class I. It gets a stronger recommendation, Class IA, reasonable, if the patient has frequent VT storm in ischemic disease or frequent VT in non-ischemic disease. Other drugs like beta blockers or lidocaine are Class I if needed.
So ablation is a core part of the strategy for recurrent monomorphic VT and SHD, especially when it becomes frequent or problematic.
Definitely integrated into the standard approach. The source also pulls from the 2019 HR-ERA's ARTHLIVE's expert consensus statement on catheter ablation of VAs. Any key updates or nuances there?
That consensus adds more detail. It emphasizes that just fixing coronary blockages, revascularization, in ischemic heart disease likely won't stop scar-based VT. You need to address the scar substrate. It suggests using CMR, MRI, and maybe programmed stimulation for risk stratification in patients with frequent PVCs, and monitoring LV function and PVC burden periodically to catch PVC-induced cardiomyopathy early. Proactive monitoring for that reversible condition.
Right. It also highlights that for patients with CRT devices, biventricular pacemakers, who aren't responding well, often due to frequent PVCs interfering, ablating those PVCs can lead to improved heart failure symptoms and function.
So PVC ablation can help optimize other therapies too.
Yes. The consensus also points to risk scores, like PAINEST, to help predict procedural risk in scar VT ablation. It strongly endorses using advanced cardiac imaging, CT, CMR, PET, for planning and intraprocedural imaging like ICE, and it explicitly acknowledges those advanced ablation modalities: contact force, needle ablation, cryo, ethanol, stereotactic radiation, electroporation, saying they offer advantages in specific situations and might improve outcomes.
That consensus really reflects the state of the art, emphasizing imaging, risk assessment, and advanced tools. It's clear this is a dynamic field. Okay, let's try to pull this all together. What were the main conclusions from the source material?
It really circles back to that tale of two cities. For structurally normal hearts, the conclusion is that VT ablation techniques and outcomes are now quite mature. It's viewed as a safe, effective, and often curative procedure. It can even be considered first-line treatment for symptomatic frequent PVCs or idiopathic VT, potentially avoiding the need for medications or an ICD.
So in normal hearts, mature, safe, effective, often curative can be first line.
Pretty much. In contrast, for VT ablation in structural heart disease, The source describes it as being relatively in its infancy compared to idiopathic VT ablation. Its primary role is as an adjunct to ICD therapy to reduce shocks, and as an alternative or adjunct to antiarrhythmic drugs.
Adjunctive therapy in SHD.
Yes. And a key conclusion highlighted is that earlier referral for ablation in SHD patients seems strongly associated with better outcomes compared to waiting until the patient is having incessant VT or shocks. Also, using percutaneous hemodynamic support is valuable for managing instability during procedures in high-risk patients.
Okay, so in SHD, adjunctive evolving, earlier referrals better, support helps in high-risk cases. And what's the final take-home message from the source for our listeners?
Two main points distilled down. First, for symptomatic VAs in a structurally normal heart, catheter ablation should be seen as a straightforward part of the management plan. It's a reliable option.
Okay, normal heart VT, consider ablation readily. Second, for patients with structural heart disease who are experiencing repeated appropriate ICD therapies, meaning the device is shocking real VT, catheter ablation is definitely noteworthy, highlighting its significant role in improving quality of life by reducing those shocks.
SHD with frequent shocks, ablation is noteworthy, important to consider. Those are clear takeaways.
You really summarized the different contexts well.
Absolutely. We've covered an incredible amount today, from the basic electrical sparks to the complex mapping of scar tissue, advanced ablation energies. It's truly a field-blending, deep physiology understanding with high-tech engineering.
It really is. And it's clear that while huge strides have been made, especially for idiopathic VT, the work continues, particularly in tackling the complexities of scar-related VT and structural heart disease to improve long-term outcomes even further.
So let's wrap up with our top 5 takeaways from this deep dive.
Okay.
1. Catheter ablation is highly effective, often curative, for VT in structurally normal hearts, targeting the specific origin point. 2. In those normal hearts, mapping techniques like activation and pace mapping, guided by ECG, are crucial for pinpointing that origin.
3. In hearts with structural disease, SHD, ablation is mainly an adjunctive therapy to reduce VT burden and ICD shocks, focusing on mapping and modifying the scar substrate where reentrant circuits form.
4. Advanced imaging like MRI CT and intraprocedural tools like 3D mapping and ICE are increasingly vital for guiding complex ablations in SHD, especially for hidden or deep substrates like LEV.
And 5. While challenges remain, especially in complex SHD, ongoing advances in techniques, technology like newer energy sources, and earlier intervention are steadily improving outcomes for patients facing these serious arrhythmias.
That covers the key points well.
It's been a fascinating journey through the heart's electrical maze. Now, here's a final thought to leave you with. Considering how precisely we can now map and target these microscopic electrical pathways and abnormal circuits within the heart, what future possibilities does this open up? Could this level of detailed bioelectrical mapping and intervention be applied to treat electrical diseases elsewhere in the body, maybe in the nervous system?
That's a really interesting question. Where could this level of detailed electrical intervention take us next?
Could we target abnormal brain circuits in epilepsy or modulate nerve pathways for chronic pain with similar precision?
It's definitely provocative. The principles of understanding abnormal electrical activity, mapping it precisely, and delivering targeted energy to modify it. Well, those concepts could potentially translate. Applying cardiac EP principles to neuromodulation or other bioelectrical systems, it certainly sparks the imagination about the future direction of this kind of targeted electrical therapy.
Something to ponder indeed, where understanding and controlling these intricate electrical signals might lead. Well, that brings us to the end of this deep dive on catheter ablation for ventricular tachycardia. We sincerely hope exploring the heart's electrical intricacies has been as enlightening for you as it was for us.
Thanks for joining us.